up, we have an aortic dissection.
With aortic dissections, there can be traumatic and non-traumatic aortic dissections. The traumatic aortic injuries usually are the patients that die before they get to hospital, so they die on scene or die very soon within their arrival to the facility.
You get two types of aortic dissection, type A and type B. Type A is when it is within the first 10 centimeters of the aorta. These patients are the more unstable ones, as there's many structures that it knocks out when it's in the first 10 centimeters. These are also the patients that present with the aortic root dissections. Type B is anywhere further along the aorta from the first 10 centimeters to the bifurcation. When it is a type A, these patients can present with an MI, they can present with focal neurological deficits due to subclavians being knocked out, they can present with a new cardiac murmur. If it is a type B, they usually present with more asymmetrical pulses, but most of them complain of a tearing pain in the chest radiating to the back. On history, you'll most likely find your risk factors for the aortic dissection. You'll feel like patients that are hypertensive, patients with connective tissue diseases, and your dyslipidemic patients are more at risk for having aortic dissections.
Patients with acute aortic dissection have pretty standard cardiovascular risk factors, like diabetes, having a family history of AAA or aortic disease, genetic diseases like Marfan's or Turner's, vasculitis or inflammatory conditions like HIV, syphilis, smoking, substances like crack, cocaine, tick, so our very typical methamphetamines like we have in South Africa, but anything that can cause atherosclerosis, in particular for aortic dissections if the patient has had previous aortic or cardiac instrumentation or surgery.
You can also have no risk factors but still have an aortic dissection. This video is just showing an aortic root dissection with a dissection flap. It's going to start moving now. There you can see the aortic root in the left lower corner with the dissecting flap moving through. So when you do a chest x-ray on a patient with a suspected aortic dissection, these patients will usually, if it is type A, present with a widened mediastinum. They might also have an abnormal aortic contour. They might have an aortic knuckle double calcium sign, but it needs to be more than 5 millimeters to be significant. Might present with a pleural effusion, usually on the left side more than the right, due to the course that the aorta takes. Late signs may be tracheal shifts or left apical cap due to the pressure effect of the blood accumulation. But what is important to remember is in 11 to 16% of patients, they might have a normal chest x-ray. When you do an ECG on these patients, you usually will find non-specific changes. You might have left ventricular hypertrophy from a chronic hypertension, any STEMI changes due to decreased supply to the coronaries. That's usually in your type A when it knocks basically at the root, when it knocks out your coronary arteries. And these patients might also present with electrical alternates secondary to a pericardial effusion because of the bleeding that's captured within the pericardial sac. So gold standard for diagnosing aortic dissection would be a CT scan. So this is just a CT scan showing the aorta coming through now. There we go. Showing the dissecting flap in the aorta. This is quite a large defect that the patient has. This is contrasted study showing you nicely where exactly the dissection is with the dissecting flap. So your management of an aortic dissection is you have your emergent priorities would be to control the BP, to control bleeding and to fluid resuscitate this patient. These can be achieved by providing oxygen if needed. You also need to have wide-bore IV access. Invasive monitoring in this patient would be ideal, especially if you can have an A-line monitoring. You need to activate the massive transfusion protocol, especially if this patient needs to go to theater. You need to correct any coagulopathy in this patient. You need to control the heart rate and the BP. This is usually done by having IV beta blockers combined with a vasodilator. You will aim for a heart rate of 60 to 80, as well as a BP of 100 to 120 systolic.